Good morning. My name is Brittany Choate. I'm Director of Programs with Saliva-Direct Inc., and it's my pleasure to be co-hosting today with Victoria, our Marketing Manager. I'm very pleased to introduce our first speaker. Dr. Illana Gozes is joining us from Tel Aviv University, where she is Professor Emerita of Clinical Biochemistry, Director of the Elton Lab for Molecular Neuroendocrinology, and part of the Department of Human Molecular Genetics and Biochemistry. She's also faculty at the School of Medicine and part of the Adams Super Center for Brain Studies and Segol School of Neuroscience. Dr. Gozes' talk is titled Oral Microbiota Signatures in Post-Traumatic Stress Disorder Veterans. Dr. Gozes, over to you.
Thank you very much. So
Wonderful.
we discovered like a quarter of a decade ago, a new protein to science that we called ADNP. It's regulated by a neuropeptide, a hormone that's called PACAP, and also we designed from it a small fragment that provides brain protection. So no ADNP, the new protein, no brain, and it interacts with multiple other proteins. Some are associated with stress. We found that the small fragment of it, isolated, actually protect women from progressive supranuclear palsy, a disease that doesn't have any other treatment. And we also are trying to develop this small fragment that we call davunatide to a disease where ADNP is mutated. But this is not the subject of our talk, so I will move immediately forward. So PACAP. PACAP, pituitary adenylate cyclase activated polypeptide, is actually a neurohormone, a neuropeptide that is associated with stress, very closely associated with stress, and regulates ADNP. And here in a human study, it was shown to be associated, the serum levels of PACAP are associated with stress, trauma in women. So there is a sex differentiation here. So we designed an experiment on our ADNP deficient animals to see if PACAP is helpful for stress condition in this animal. And we exposed the animals to constant illumination, and we looked to what PACAP does. So we saw that it protects, and here it protects the females against stress, against the stress in animal model, that's where you can actually measure the reaction to stress, open field, and also elevated plasmas, it's called. And we found that the protection was associated with plasma cortisol levels, which are providing protection actually against stress. And then we also saw that ADNP, our protein that without it there is no brain and is associated with stress, is actually indeed associated with stress and associated with the expression with a PACAP application differentially in females and in males. And when we looked at, now these are soldiers from Israel, from the Israel Defense Force. And what we saw there is that when the soldiers were exposed to stress, ADNP level actually changed, and they were correlated with the cortisol level. So we know that ADNP is associated with stress, and then we said, let's see if we can actually stratify people according to the ADNP level and know if they are will be protected against stress, like in stressful situation or not. So we decided to go after saliva to look for ADNP levels and also PACAP levels and maybe other genetic influence, so the human DNA. So this is the summary of what I just said, so we know it. And another thing that I wanted to say before that is also that ADNP is associated with the microbiome. So we saw that in our animal models, and we saw that there is a signature in the ADNP mouse model where the several bacterial species are changing, and then these are corrected by the small fragment from ADNP and associated with the stress. So we found a bacterial species that are associated with stressful behavior, like in the open field, and also with learning and memory. And so this brings me to the actual study that I want to go more in depth into, and so the idea was that we wanted to look for ADNP and PACAP in the saliva, and these were a cohort of soldiers that we looked at, of almost 200 soldiers, veterans actually, that suffered from post-traumatic stress disorder because of combat exposure. So the title of the paper that we published was Oral Microbiota Signatures in Post-Traumatic Stress Disorder Veterans. And this presentation was actually prepared by a student, Lior Rennert, who is now a PhD almost, and she's a psychologist. And this was a collaboration between psychologists and biochemists, like neurochemists like myself, and also bioinformatics. Guy Shapira was the bioinformatic guy that that led the bioinformatics together with his mentor, Professor Noam Sharon. And Ella was mentored by Abraham Sagi Schwartz. So when we looked at first choosing the cohort, we took a cohort of veterans from 1982. So these are people that have been in several wars and suffered PTSD or combat stress many years ago. And this cohort is studied very extensively by Zahava Salomon, and here are some citations. And originally I was thinking that maybe we can follow them across the years, but since we decided to go on the microbiota, eventually that was difficult to do. And also saliva is a new diagnostic field. And beforehand, people used to take blood. So this is again the description of the cohort. So we had, it was the fifth measurement of their actually psychological behavior. And as I said, it was about 200, but precisely 189 people, and 19 still suffered PTSD since 1982. And this is very high levels in comparison to the general population. And so first we looked in, and that's the beautiful bioinformatics work that Guy Shapira did. So we looked at, and we tried to correlate the social support, all the behavioral, all the psychological measures versus the microbiota signature and the environmental signature, the environmental effects. And we looked at the saliva. And we looked at the saliva originally looking for genes, for human genes. So we did RNA sequencing, we looked for human genes. They were very scarce. But what we saw was the dramatic effect of the bacterial population. So we decided to look at the bacterial population at our oral microbiota, or the subject's oral microbiota. And what we saw is correlation of the microbiota species with like environmental stress. So for example, the air pollution, which is kind of said here, the air pollution was a negative effect, while years of education actually correlated oppositely with the, so education actually protects against PTSD. So many years of education protect against PTSD, so I would never have stress. Air pollution is actually a determinant for. It's better to live in clean air areas, and we saw correlation between the bacterial species and the. And this is actually not shown here. This I'll show you in a minute. But we saw the health conditions correlated also with the general health conditions correlated also with the PTSD symptoms. So this is the paper which was published and is highly cited, and we got also a lot of press from the paper. And so this is what I was saying, is that when we looked at the specific individuals, and when we look to see and compare with like our genome, the human genome versus the bacteria, what we saw was bacteria. So the saliva contains, the way we took it, thinking on one way and getting the other, we saw many bacterial species, and then it became a question of bioinformatics to try and sort it out and see if we can define a signature that will take it further as a diagnostic. So this was the idea. And so here you see the beginning. And then what we saw in like, again, looking in general, we saw that there was a reduction in the diversity. It wasn't robust, but there was a significant reduction in the diversity of the bacterial species that we saw in the PTSD, the healthy, those that are not PTSD anymore. And you see there was a distribution of the bacteria in terms of other health conditions. And so we looked at the host. We actually looked at all the bacterial species known, and we compared to the outcome, to the psychological outcome. So this is one way to present it. Another way to present it is here in this heat map, and you see that when you look, and so this is the all microbiota, the saliva microbiota. I don't know why this came up. The saliva microbiota that we see, and you see that there was a correlation with all the outcomes, the psychological outcomes were kind of correlated with a specific signature versus other health problems that are correlated with other bacterial species. So there is a difference, and it depends. Like smoking, those that smoked had one specific signature, but all in all, the different characteristics of these people, the different psychological characteristics were associated with a certain host of bacterial species. So if we dive more specifically into this bacterial species, you see, and we kind of highlighted them in blue, in light blue. You see, like with anxiety, you see the Firmicutes, with hostility, you see similar, you see the bacterial, I can't pronounce it correctly, the Bacteroidetes, and you see them here as well. So you see that the anxiety, hostility, all sorts of symptomatology that is associated with PTSD, even memory difficulties, and the reactivity, so it's like being aggressive, and the severity was connected with a similar host of bacteria, and we presented it. And years of education, on the other hand, as I saw before, was actually protective. So this is very interesting. And here we plotted it a little bit differently. And what you see here again is that, for example, here you see that the Bacteroidetes, you see that it's going one way with higher, with more years of education, but then if you look at the total severity score, more reactivity symptoms, and the psychopathology and memory difficulties and anxiety, they all go the other direction, meaning that if that education will be protective. And I want to add another thing about education, is that has been shown also in Alzheimer's disease, that education is protective. So it's like when you want your muscles to be strong, you exercise. So if you exercise your brain, you listen to my talk now, your brain is active, then you will be protected, and you will be not only protected against Alzheimer's disease, but you will be protected against stress. And actually PTSD, stress, and depression is a risk factor for Alzheimer's disease. So it's very important to engage in activities that will activate your brain in a positive way. And also here we see the same with the Firmicutes. I hope I'm saying it correctly. Again, that the years of education goes one direction, and then the other goes the other direction. So we saw this correlation, and which give us a signature. And we know that this will protect against stress. So on the one hand, maybe we can stratify people if they have this high Bacteroidetes and Firmicutes in, sorry that I'm not saying it correctly, in the saliva. And it's very easy to take a saliva sample, even from a person who is suffering from PTSD. Then maybe we can stratify people, and by knowing that, maybe we won't put them under stressful situation, try and help them this way. And what was very exciting to us is also that I found, as I was writing the paper, I found the paper in the literature looking at macaque monkeys and actually putting them into a depressive state and then checking now the gut microbiota. And they found exactly this same species that I've shown you in the previous slide. They found also in the macaque monkeys, meaning that it's not, we looked at everything. We did complete RNA sequencing of the entire flora that we had in the mouth. And here we actually found that this is similar in an animal model under laboratory conditions, found exactly the same kind of finding. So meaning that we actually have a signature that would be very interesting to follow up on and to make sure that people who cannot cope with stress would not be exposed to stressful conditions and also maybe be able to treat them. Another thing that I didn't put on the presentation, but I did write in the paper, is that we found a connection with actually bacteria that have reduced energy metabolism. So reduce the production of like NAD+, which is associated with energy, and so a supplement of NAD+, which some people think is against aging, it could actually help this cohort of people. So by this, I actually am ending my talk. So maybe I even ended early, and I'm thanking you very much for your attention and for inviting me over here. And I hope I was clear, and I'm happy to take questions.
Thank you, Dr. Gozes. Appreciate it. If anyone does have questions, please feel free to put those in the chat or raise your hand, and Victoria can make sure to unmute you and welcome you into the conversation. Well, Victoria, first let me ask, are there any questions that have already come through?
None that I can see as of now, no.
Okay, then that's fine. I actually had one of my own when I was hearing about the way that this program or this project initially came about with this collaboration between microbiology and the psychology department. I was wondering if you could share more about why that partnership and why that collaboration was something you thought was really necessary for this project and contributed to the outcome you were able to see in the results.
So we wanted to have a big cohort, a relatively big cohort, and that was one reason. The other reason was that, as I said, these people that we tested have undergone several wars and have undergone many tests. So I thought that this would be an excellent cohort. And Zahava Salomon, who actually provided the cohort, she won the Israel Prize. So we have a big prize in Israel. It's called the Israel Prize for really caring about these people who are the war with veterans that suffered and trying to help them. And I thought that this might be helpful also in understanding understanding how can you protect people against stress that will end up in a disease, in PTSD, in post-traumatic stress disorder, and also looking at the saliva as a very easy way, a non-invasive way for diagnostic. And I think this is important because, when you put two people in the same stressful situation, one can become sick and the other will pass it as if nothing happened. So the question is, how can we help the population to live better? So this is like generally speaking. So that was why I wanted to work with the psychologists. And but of course, we needed people from all over the gamut. So we worked with we also worked with the psychiatrist of the army, and we worked with the psychologist, and we worked with the bioinformaticians. So it was kind of. But we were thinking that we will also know what our genes will be. That was the original, to see if we have some stress defended genes that defend us against stress. But we ended up finding bacteria that defend us against stress. So and as I added the education bit, which was something that was unexpected a little bit. Although, as I said, we know it also in Alzheimer's disease cohorts.
Mm-hmm. Yet another reason for us all to maintain a lifelong learning perspective, I suppose, amongst so many other things.
Yes.
but I did have a follow-up to that, and that is, what do you think, or where do you think this field is heading next? What else might your team look for in saliva, or how else can you do you think that saliva-based testing, since as you mentioned, it's non-invasive, could be applied to similar research studies going forward?
So I think it could be diagnostic for many diseases, as I showed you. Actually, what I showed you in my introduction, which I went through very fast because I thought I didn't have enough time, it could also be diagnostic like in autism, and it could also be a diagnostic in neurodegenerative diseases. And there are also like fecal transplants that are going on. So understanding what's wrong with the, and instead of, you can do it also in the fecal test, but I think the saliva, as I showed you in the monkeys that I showed in the last slide, it actually was fecal samples and it gave the same result. So I think the saliva would be easier to look at and could give you a similar data, and maybe also by oral application like Microbiota we can actually treat. So I think that it can go on many different diseases, and there are studies also looking at diet. Understanding the saliva microbiome can also help in diet, and so we will all be very good looking and healthy. So that's the idea.
Thank you. Appreciate it. And it's interesting that you mentioned those couple of topics and potential areas for expansion. We are fortunate to be hosting a conference next month in Washington, D.C., and have a couple of speakers that are going to be expanding more on some of just what you mentioned. And so if anyone is interested in joining us or has some space in their calendar for next June, Dr. Alexander Zetso is going to be presenting on the measurements of neurochemicals in biological samples. And then we're also going to have Dr. Carolyn Bannister joining us, and she's presenting on saliva-based concussion diagnostics. And so it's really interesting to hear not only your presentation, Dr. Gozes, but also thinking forward of these additional conversations we're going to be having as part of the conference that's happening next month, and just thinking about where we're all headed. It's very exciting to get to learn how saliva-based testing can be used for more than just how our team got its start with infectious diseases and diagnostics. And so really appreciate you taking the time to join us today.
Thank you very much.
Terrific having you. Up next, we have another presenter, Dr. Lior Rennert, who's joining us from Clemson University. And there he is an associate professor and biostatistician with the Department of Public Health Sciences, as well as the director of the Clemson Center for Public Health Modeling and Response, and part of the College of Behavioral, Social, and Health Sciences. Dr. Rennert's talk is titled Saliva-Testing for Outbreak Containment. Dr. Rennert, over to you.
Thanks for having me here, and let me just share my screen. All right, so it is an honor to be here today. I'm going to be talking about how saliva-based testing helped guide our university strategy and contain outbreaks throughout the COVID-19 pandemic, and how we plan to currently utilize these tests going forward. Just a quick background and a reminder, although I'm sure most of you have seen some version of the slide many times. We know that the original SARS virus infected about 8,000 people, killed 10% of them. And that had to do with the infectivity rate. It was just not as infectious as SARS-CoV-2. Now, this virus spreads through the air, and if you inhale these droplets, you get infected. So it spreads very fast. And we saw that SARS-CoV-2, even though that death rate was lower, so many people got infected that we just had a lot more severe outcomes. To put things in perspective, we have about 1.2 million deaths in the US, 7 million deaths recorded worldwide. That number is expected to be much higher. But that 1.2 million, again, just to put it in perspective, that is more American lives lost than in all the wars combined in US history, including the Civil War, World War I, and World War II. So the focus of this talk is going to be, how can we strategize to mitigate the impact of these pandemics with a specific focus on the role of saliva-based tests? And I'm not going to go over this slide. I think we all understand exponential spread. you have one infection with an R0 of 2.5. Within 30 days, every person will ultimately infect over 200 more people. If you can reduce exposure, then that will happen at a much smaller rate. So what we're going to see here is if we can quickly test and isolate people, we can reduce the exponential spread of the disease. It's not just about, in a university setting, testing individuals just to get university prevalence down. That also has an impact on mitigating transmission into local communities. And that's just because the viruses don't care about boundaries. They move very quickly. And not only can they move into your local community, but we saw this at the beginning of COVID. If you have uncontrolled university spread and now have to shut down, you're now going to be sending a lot of sick students home back to their parents or grandparents in local communities and causing more outbreaks. So again, just trying to put us in the mindset of the beginning or middle of 2020 and where we were. A big problem in 2020 was resource allocation. First, it was ventilators, and then masks, testing kits, vaccines, and treatments. And this poses daunting decision-making challenges for public health officials. That includes hospitals, universities, and other large institutions. So we have to be efficient with how we allocate our resources. Fortunately, the saliva-based tests developed by Saliva Direct help us overcome a lot of those limitations, as we'll talk about here. But we didn't have those tests at the beginning. And we had to get a little bit creative at Clemson. So the first thing we did was we delayed the start of in-person instruction. That allowed us, we delayed it by about a month. That allowed us to ensure we had sufficient infrastructure for COVID-19 testing, isolation beds, and other essential resources. We had about 1,200 tests per day by the start of in-person instruction. To put this in perspective, we have close to 25,000 students. So while it's a large number, not necessarily enough to really mitigate or contain outbreaks. So we needed to, to maximize effectiveness. First, any individual wanting or needing a COVID-19 test had one. The remaining tests were used for surveillance testing. And then if an outbreak was detected, we stopped the surveillance testing and used all of our tests to test the hotspots, so specifically residence halls. And we see that using this strategy was twice as likely to detect positive cases compared to standard surveillance testing. This was a procedure I was in charge of, and I'll go into a little bit of detail before I get into how the saliva-based testing and the mass testing really helped us not have to put together these piecemeal strategies to go forward. So here's how the targeted testing worked. First, we randomly selected students for random surveillance testing. If we saw 2 or more cases from the same residence hall, we just tested that entire residence hall. So this plot shows the number of detected cases for a sample of 6 residence halls here at Clemson. The blue points indicate the total cases detected through random testing, and the red points indicate the total cases detected after targeted testing. In this example, resident halls B, D, and F were selected for targeted testing because they crossed the threshold of 2 cases from surveillance testing. We did not target residence halls A, C, and E down here because they did not meet the threshold and were therefore at a lower risk of an outbreak. Just really behind the scenes, right? You have to put all this together in real time. So you have to know your testing data platforms, testing outcomes for each student, where they live. You need to generate that email listserv so that you can actually tell students to go ahead and get tested. You have to make sure that exclusion list is very up to date so that you're not sending people to get mandatory testing who shouldn't be. There's a whole other HR, PR aspect to this that will really slow things down. So having a very good data management system is extremely important in these settings. And we had, fortunately, we had that at Clemson. So this figure just shows that our targeted testing, represented by the gold line, substantially drove down prevalence. Our targeted tests were twice as likely to detect positive cases compared to random testing. The prevalence just from the random testing is shown by the red line. So the models that we developed showed that this strategy prevented a 154% case increase throughout the semester. And importantly, by reducing university prevalence, it also helped reduce university to community transmission. This is an effective use of limited resources. Now let's get into our weekly testing. So Clemson's Ready Lab, I'm sure a lot of you are familiar with Delphine Dean, began ramping up saliva-based PCR tests for COVID-19. By the spring 2021 semester, we had the capacity to implement weekly testing for all university students and employees. And this strategy kept COVID-19 prevalence to a near record low nationwide. Also to mention, these saliva-based tests were so easy. I mean, students literally had to come in, spit in the tube, and they would be out in a minute. I mean, you're going from just scanning your phone from walking into the building, walking through the lab, and you are just out. It was such a fast process, really just mitigated any of the difficulties you have with supervised nasal swabs or other types of tests. And this is just showing our weekly prevalence for students during the Delta surge last fall. While the overall bar seems high, the number at the top indicates prevalence, and we can see that 1.6% prevalence is pretty low, and that was just at a peak. Surrounding institutions range from about 2 to 5%, so anywhere from 1.25 to 3 times as much. And the problem is that if you're going to test less, you're going to increase your disease spread. That's ultimately more symptomatic cases in the long run. So even though there was this, I don't want to, fear may not be the right word, but this thought that, hey, if you test more, you're going to find more cases. Well, not necessarily. If you test more and you can isolate cases sooner, the disease will spread much less, and you will actually detect less cases overall than what would have happened if you let the disease go uncontrolled, and now you're only seeing symptomatic cases, but the pool of cases is so much larger that you're just going to see more cases overall. So this is the Ready Lab, conducted over 1 million COVID-19 tests through saliva-based tests throughout the pandemic at our peak. And this was done by Delphine Dean. She's a professor of bioengineering and now chair of the bioengineering department. Up to 9,000 tests a day, results in under 24 hours, sometimes in a few hours, at a cost. And here's the other thing no one talks about. Well, I'm sure everyone here knows. It's a mere fraction, less than $5 per test. When we were in the earlier testing, I was showing you those were in our targeted testing strategy. Those were nasal swabs. Those tests, I think, ran us about $80 a test. So just, again, to put things in perspective, massive cost savings, and we got the results much faster, and they were less invasive on every metric. The saliva-based test just beat out your standard nasal swab. The Ready Lab also provided COVID-19 tests to over 60,000 members of our community and to other colleges statewide as well. And the partnership with the city of Clemson and local physicians really was just able to provide accessible testing to community members with quick turnaround times. This was extremely popular because it allowed not only people to actually get a test, and again, make it easy. You don't have to pull into a CVS and wait 15 minutes, and that's assuming you're in a community that has access to that. And not to mention the days you had to wait for your test and scheduling the appointment, right? You don't get to go when you want to go. You have to go whenever they have an appointment. And so not only was it convenient and allowed people to know if they're sick, but these sick people presumably also isolated when they found out, when they got a positive test result, and it allowed members of the, and it just allowed us to slow down community spread. And importantly, it also allowed us to identify variants of concern when they entered our community. So overall, it really had a very big impact. Just briefly, when we talk about university or any disease mitigation at the university or community level, we have to talk about vaccination. That was the other big piece of the puzzle that came in during the fall 21, during the winter of 2021 into fall, but we made vaccine clinics available at our basketball stadium. We literally placed this right next to the testing site. We could provide first, second, and booster doses. And this is a true story, but I remember when we had mandatory weekly testing, and you would go in, you would scan, quickly just scan the QR code on your phone, get your test. And I remember as soon as you do that, you get a text message saying your test was initiated. I remember doing that and then walking over to get my booster dose right there, immediate, shot. I was out of there. By the time I got out, you know that when you get a text message, at least on the iPhone, and you don't read it, you get a reminder 2 minutes later that your phone buzzes. I got that reminder after I'd left the building. So I was able to get my saliva test and my booster dose all in under 2 minutes and just walk out. So it just kind of shows the feasibility really matters. As much as, we hate to admit it, human beings, there's probably a better term we could use in public health, but some of us are lazy and we're not going to go very far out of our way to necessarily get a test or get a booster. I know people in this crowd will, but your typical community member, and I don't even want to say typical, let's say some community members, as we know, we had to make it easier for them. So saliva-based tests are a perfect example of that. We, of course, ran awareness and promotion campaigns. Fortunately, there was not a lot of hesitancy to take to spitting in a tube, lots of hesitancy to injecting a vaccine. So we had to create one with our public health team and a student-led initiative. We had to create material that we can disseminate on vaccine safety and effectiveness. A lot of credit goes out to Clemson University and our leadership for letting us do this and supporting this. And importantly, they offered a $50 incentive if you offered proof of your vaccination. So that immediately got, I don't know if it got our rates up really high or it immediately got people showing that they got the vaccine, but we had some pretty good rates there. Of course, we did have to, there was still a lot of vaccine hesitancy, especially in our community. So we had to create informational flyers, really just emphasize that the vaccines were safe and effective. So we had some additional campaigns going around. Now these numbers are from the earliest vaccination studies. We obviously know that after when Omicron came along, vaccine effectiveness waned, you needed to get your booster, so on and so forth. And I have to mention that because, of course, as we all know, you get angry people who say these numbers aren't right, or these, you're misrepresenting the effectiveness of vaccines and they don't work and blah, blah, blah. So you always have to be careful about presenting information and taking down outdated information. Again, just for this group, as we all know, the vaccines were obviously effective, continue to remain effective. Importantly, very minimal side effects. All right, so how did we actually know what strategies to implement? Well, that came through a lot of data-informed decision-making from our public health strategy and modeling team. It is important to note, and I emphasize, the strategies and models that we came up with, they weren't just coming out of the top of our head. These were, after we implemented and developed these models, they were validated by some of the top scientific and medical journals. So just going over some of our work, phase reopenings and their impact of that, pre-arrival and arrival testing. I didn't talk about that too much, but that was another huge thing with saliva-based testing, is that as soon as students came back to campus, we could test everybody within a couple days. I mean, that was just an incredible thing to be able to do with a quick turnaround time. So we talked about our surveillance testing strategies. We also compared those to symptom-based testing strategies as well. We had to compute protection from previous infection and vaccine effectiveness and waning immunity, analysis of SARS-CoV-2 variants, and then the effectiveness of quarantine strategies, and essentially integrating all of this into a modeling toolkit to inform university mitigation measures. I'm just going to skip this slide. Just know that all of this information was built into a mathematical model that can tell us how many cases we can expect, how many students we expect to, or how many isolation beds we will need, how many students we expect to be quarantined at once, and then evaluate different testing strategies, how often we need to test. So the reason all this is important is just because modeling, in the fall 2020, especially spring 2021, when we had some data, pretty straightforward. But as you started to get immunity from previous infection or vaccination, you really had to take all of this into account. So we were able to build all of this into our modeling framework. Oh, yes, go ahead.
Oh, that was just me letting you know you've got 5 minutes. Thank you.
Oh, awesome. So I'm just going to skip through this very quickly and just get to some of our current work. So vaccine immunity against Delta wanes over time. We didn't find the vaccine was very effective against Omicron. That's the 2-dose series. You got your booster dose that increased your protection. And again, this is just protection against infection, protection against hospitalization, much higher. So we extended our models. And importantly, what we were able to do with these models, and primarily due to 2 things, our ability to do weekly pre-arrival and weekly testing and vaccines, means we were able to get rid of a lot of strategies that just didn't have an extra benefit. So we're talking about, delayed opening or online instruction or social distancing, where once you were able to keep prevalence really low on campus through these other measures, we were able to return to a much more normal and, standard operational workflow. And we can see that even as we reduced our measures, we don't really see a major increase in prevalence compared to fall 2020. As soon as we were able to do weekly testing and then vaccines, prevalence stayed really low. Of course, we had mask mandates in class, but we also know that when students aren't in class and they're out, anywhere off campus or, at their social gatherings, they're not wearing masks. That's when the disease transmission is happening. And even without that, we still saw, record low prevalence, at least in the nation. I want to just very briefly talk to you about our center that I run here, the Center for Public Health Modeling and Response. Our goal is to improve health outcomes by creating usable knowledge for clinical and public health decision makers. And importantly, we want to assist the ability of health organizations and communities to prepare for and respond to public health threats. So this is the conceptual framework. The first step is to integrate data sources and apply statistical analyses to conduct disease surveillance and detect local hotspots. We then feed this data into dynamic simulation models to predict which regions will benefit the most from essential resources, and then integrate these models into a toolkit to help direct field level interventions. So the diseases of interest right now are the respiratory viruses, substance abuse, primarily opioids at this point, HCV and HIV. And the idea is if you do strategic planning and response and efficiently allocate resources, you can just save more lives. We saw from the targeted testing approach, if you move your tests to where the hotspots are, you're twice as likely to actually detect a positive test. I want to briefly talk to you about the CDC Center grant we just got from the Center for Forecasting and Outbreak Analytics. The title of our project or center is called Disease Modeling and Analytics to Inform Outbreak Preparedness, Response, Intervention, Mitigation, and Elimination in South Carolina. So we are one of 13 funded network partners of the Center for Forecasting and Outbreak Analytics. And we're in a center of integration. So what we do is we pilot test disease modeling tools in state, local, and national organizations to see how useful this is for public health decision makers. And I want to quickly get into how what we are doing here. So overall, we're building a statewide network for outbreak detection, forecasting, and emergency response. We're going to be integrating electronic health records, wastewater samples, and digital trace data. So that's, you can think Twitter or X. We'll integrate that into a decision support toolkit and inform public health response. And I'll just focus in on the public health response that's related to saliva-based testing. I won't go into all of our partners, but I do want to talk about how this is going to inform COVID-19 mobile testing and vaccination units. Mobile vaccination units were a very key part of our pandemic response and mobile testing units. Prisma Health, they're the largest non-for-profit health system in South Carolina. They serve about 25% of of the state and cover about 50% of counties. They administered over 12,000 vaccines in a one-year period, primarily to medically underserved communities, especially those without insurance or who were on Medicaid. Clemson Rural Health provided testing to over 11,000 individuals from underserved communities. So what we are going to do here is we are going to identify hotspots and then deliver these mobile health clinics to provide saliva-based tests and vaccines to underserved communities. And the saliva-based testing is really important because this is a process that needs to move quickly. We need fast turnaround time, and we need to keep costs down. You know, this is a service that we are providing, we are covering, so the cost is also a huge factor. The idea is to build a toolkit that, based on what your mobile unit supply is, where your testing supply is, your vaccine treatment supply, where you can have the greatest impact on reducing hospitalizations. So that's one thing we are working with, and we are also funding these mobile health clinics to go throughout the state. Thank you.
Thank you so much for sharing all that information about where your team has been, the success you had, and where you're heading next with this Prime program. It's very exciting to hear about, and I'm certainly already wondering when that toolkit is going to be available, since Saliva Direct does do a fair amount of community engagement programs, and we have our own mobile testing program that's going to very similar communities. So, Lior, I'm going to be in touch with you very, very soon.
Yes, please. Yes, that would be amazing.
Yeah. All right. Well, you can look out for that. I will look forward to it. While we're waiting for questions to come in from others in the audience, please, again, feel free to post those questions in the chat. Victoria's collecting them. Just thinking about the information that you were sharing, when you're looking ahead at doing that next pandemic response or outbreak preparedness program, what criteria did your team see, or do you think is really most important for activating those surveillance testing programs, either at residence halls or out in community? Is there some high-level thought that you're already thinking is going to be a good leading indicator for this toolkit you all are building?
Yeah, so that's a really good question. At the time we started working on this, we were in the middle of a health emergency. So we saw a very big impact. If you can if you can get to a community where right before the outbreak really gets too large, right? Because if you get there too late, it's just not going to make as big of a difference. So you have to get there at the right time. And especially, you know, you also have to make sure people are utilizing your mobile health clinics. So you don't want to park it right next to a hospital or testing center. So you have to identify the medically underserved communities who are at high risk. And the way we would really do that is through mathematical modeling. So this is where you are now. This is the protection you have in the population. These are the resources you have. And this is the expected number of severe outcomes we expect in this particular community. Now we're focused on the zip code level. We hope to get more granular than that. Anything beyond that is just not very informative. You know, it doesn't tell you where to park a mobile health clinic, you know, in a county. Now, to your question, how do we decide that? In a non-health emergency setting, I don't think the impact is as great, but you don't want to wait for a health emergency to start piloting these programs and seeing, you know, where you're going to go. So if you're going to be using your mobile health clinics, even if the difference between the high risk communities and another community isn't as large, it is still worth doing because now you're getting your protocols in place. And it also helps, at least we saw in a health emergency, to take the pressure off of that decision maker, because there's a lot of demands for these mobile health clinics. So if you have some objective criteria to do that, that helps a lot. I don't know if that answered your question.
It does. I think that objective criteria is really helpful, and you sharing about those pilot programs and getting things ready, I think, is something that our team has been seeing. And before I joined this team, I was doing testing and vaccination response and during the pandemic, and we certainly learned a lot. And I was thinking about the community relationships and the engagement that you were sharing that your team has done, and would be interested to hear how you're working or continuing to work with the community to keep those connections and partnerships alive, because I imagine that's just as important as having those testing clinics in place.
Absolutely, yes.
Yeah. Is there anything in particular you all are doing to continue have that cohort meet or stay in communication in these kind of in-between times?
Yeah, so that's a really good question. Because we're not in a health emergency anymore, the mobile health clinics, a lot of them have been repurposed to deliver other types of healthcare. So it may be standard healthcare. We do a lot of HCV screening with Clemson Rural Health. Prisma Health is doing. We currently have another NIH grant to deliver opioid care. So opioid preventative treatments and not just preventative treatments, but importantly, medications against opioid use disorder for those on it, and peer recovery coaches through mobile health clinics. So through these processes, we do still need to engage with community partners. So because the mobile health clinics are in use, that is still happening. Maybe not at the scale that it was, but we still have as part of this proposal, we are compiling lists of all of our community partners and contacts, so we have them on hand. And as part of how we're going to pilot test these is the idea would be, have these saliva-based tests on board the mobile health clinic, because they're very easy they don't take up much space. They're just so easy to actually distribute that we can just bring this into our cascade of care.
Thank you. Appreciate that perspective. And also really great to hear that the saliva-based testing is continuing to be well received by those who are running these types of testing programs and by the community. It's always great to have those kind of endorsements for whether it's our protocol or someone else's. This continued movement into saliva-based testing is certainly something that we're all very interested in, hence all of us being on this webinar and on this call. Thank you.
Absolutely.
I did see that we had one question that actually came in a little bit late for Dr. Gozes. So if you don't mind, one question for you before we maybe transition out or see if there are other questions from the audience. And Dr. Gozes, this question came in, and it was a question about, were the results that you shared also controlled for general mouth and dental issues for changes in bacterial levels that may have corresponded to periodontal disease, which might have indeed an effect on stress?
So we didn't actually, but I don't think that there were these kind of problems. I mean, there was nothing that was reported. We actually spoke to all the cohort, they were interviewed, for all the diseases that they had. So this didn't come up as something that was a major problem. And so, but we didn't go very deep into it. So it wasn't a major problem. People didn't report on it. So I don't think that it skewed the result. And what is really interesting is that when we compare it to the macaque monkeys, as I said, and there it wasn't saliva, but it was fecal measurements and gut measurements. So this is a different story. And regardless, the same signature was observed. And also when you have periodontitis, it's specific types of bacteria that came up, and this did not come up in our analysis. So the answer is this didn't. It would have been good to control for that in retrospect, but it wasn't necessary in this particular case.
Thank you. Appreciate you answering that question that came in for you. I would
Thank you.
like to, of course, thank both of our speakers, Dr. Illana Gozes and Dr. Lior Rennert. Thank you so much for joining us today and sharing about your work and where you're continuing to go. For those that have joined us and would like to receive credit, PACE credit for continuing education for being a part of this, remember to submit that survey that Victoria is going to be sharing out. Thank you all so much for joining us. Take care and have a wonderful rest of your day. Thank you.